एग्जाम का शेड्यूल तो नहीं आया
किसी दिन ज्वाइन नहीं किया तो स्पीकिंग थोड़े और लोग आ जाते हैं स्टार्ट करते हैं।
कोई आया नहीं अकेला है उसी के पास सारी की होगी वही दबा देगा कोई बात नहीं हम अपना काम करते करता रहेगा
एक्चुअली ये कहीं कह रहा था कि लास्ट टाइम शायद उनको ज्वाइन करने में कुछ प्रॉब्लम आया या कुछ हुआ
थोड़ा टाइम पहले भी
क्लास वीक
बोल रहा था कि बहुत सारे स्टूडेंट ज्वाइन नहीं कर पाए
बिकॉज ऑफ
हाँ
their problem
सम टेक्निकल
their problem
हाँ तो इसलिए अपोज करवाने के लिए
कोई बात नहीं अगर देख लो अगर कोई ऑर्डर करता है उसको कॉल कर देंगे
पीयूष को
हाँ
चल वो तो दिखा रहा है फिर उसको ज्वाइन कर चाहिए
इसमें वो पॉसिबिलिटी नहीं है चैट की कोई
कर सकते हैं
तो इसको लिखो ना पीयूष मेरा अदर्स ऐसे करके कुछ लिख दो
ज्वाइनिंग लिखा हुआ है उसने लिखा है स्टूडेंट्स आर ज्वाइनिंग
पर ये आ गए ना 4 तो और
हाँ जी
आ जाएंगे
तो मैंने वो
नहीं ये तो भेज दो कोई बात नहीं कितनी देर का मटेरियल है 1 घंटे का लगता है वो तो
हाँ 40 मिनट्स
नहीं ठीक है कर लो फिर तुम हाँ कर तो रहे हाँ हो जाएगा कर लो
Hello everyone. So this is the first of 4 revision classes that you're going to have in pharmacology. So today I'll be talking about ultra short assessment exercises or simply put spotters. We've already had this discussion earlier, so it's just a quick revision. We're just trying to give you an idea about what kind of spotters, different kind of spotters that you may get. The different variations of each question I'll discuss as and when we go. So as per your request, we've actually divided it into 3 classes. So as far as possible, we've divided it according to the semester. So today I'll be taking the 3rd semester systems, general pharmacology, autonomic nervous system and CVS related spotters. The other classes for the 4th semester, we've tried to keep CNS, endo, then autocoils, GIT, and the last whatever antimicrobials and a few other miscellaneous topics have been covered for the 5th semester spotter class. Okay, so try to pay close attention to what we're going to talk. Normal conversation or discussion with you would have been better, but we'll try to put forward as much as we can so that you understand it better. And the reason I think it will be useful for you people also is because these spotters are very scoring. So even if it is 10 marks or 20 marks, it's very easy to get marked, very easy to score in these topics actually, because they're very small questions. So for each spotter you will have approximately say 1 or 2 options, 2 sub parts which you need to answer. And we take these questions not just from your theory, but whatever practical is also taught, like practical classes that are also taken for you people. Okay, so try to pay attention as we go. It's not a very long class, it will be very short, very brief, but hopefully we'll cover as many variations of questions as possible. Please remember, these are not all the spotters that you will get. There can be different spotters as well. It's not a comprehensive list. We are just sensitizing you to the type of spotters that you can get. But don't worry, they're not very hard either. Alright? So let's start with general pharmacology. So let's look at the first spotter. One variation of spotter is where you're given a figure and there will be a question associated with it. Make sure that whenever you get such a figure or such a spotter, that you see what the question is more importantly. Sometimes you just expect a question in your head and you answer accordingly, but just pay attention what is being asked. So what type of antagonism is being shown by substance A in reference to drug X? So now if you see, this is a log dose response curve which you are familiar from your theory classes. So the main dose response curve is that of drug X. Alright. So if you see distinctly, they are asking about substance A. So substance A is probably, we are talking specifically about antagonism. So anything that shifts your curve to the right, but you are able to reach the maximal effect as shown in this figure for substance A is competitive antagonism, right? So if the graph is shifted lower, the maximal effect is not reached, it is more likely that the substance is non-competitive in nature. The antagonism is non-competitive. So related questions to this, one is straightforward, like I said, it could be the other substance also, hence the emphasis on reading the question in detail. Second thing, it could just be a DRC and you could be asked to comment on the importance of the linear part, or you could be asked what this portion is, why is there a plateau over here, or why is there a plateau over here, why is there a straight line over here, this 25 to 75 or 20 to 80 as people refer to it as. So you can be asked to comment on the linear portion as well. So be very careful about what question has been asked. Alright. So another variant, this for the last class, if you would have, anyone who would have attended, it was on nuclear receptors. Here we've shown a ligand gated ion channel. See, these are concepts that you know, you've heard of, you've read somewhere, either in general pharmacology or you have touched upon them in different organ systems. Alright. So again, like I said, this is a figure from site itself, it's an ion channel. Now the drug is giving you the question itself is giving you a clue that it is actually a ligand gated ion channel, right? So if you think a little bit about ion channels, you remember they are either ligand gated or voltage gated. Ligand gated ones are the ones we are interested in terms of pharmacology, because you can add drugs or you can find binding sites by which you can modulate their activity, okay, which could have some potential in diseases, right? So if you have this question, see the question. So name one drug that acts via ligand gated ion channel. You can very clearly see this is a GABA chloride channel, right? It's a GABA A channel. So first thought that would come into my head is, I'll think about benzodiazepines, right? Barbiturates. But it is asking you any drug that is acting via an ligand gated ion channel. So whatever you can remember, even nicotine would be a valid answer, right? Again, if you see the question, name one drug that acts. So it's not telling you whether it is an agonist or it is an antagonist. So both answers in this scenario will be acceptable. So instead of nicotine, if you could give me varnicillin, which is used for anti-smoking, for smoking cessation, that is also an acceptable answer, because that acts via blocking this activity. It has an antagonistic effect on the ion channel. So both are acceptable is what I am trying to tell you. So pay attention whether the question says agonist or antagonist. It's just asking for any drug for that matter. Alright. So looking at the second part of the question, name one condition where this drug is used. Be very careful, whatever drug you've written in the first option, you have to write the use for that. So whatever I'll discuss today, yes, a lot of it will be pharmacology, will be somewhere or the other, a revision of things that you know, but also it's going to be a, kind of a test for your common sense as well. Please do not leave that at home while you're attempting these questions. Let's look at the next question. So before this, the two questions that we've discussed were figure based, right? There was an image on the side and you had to answer questions that were somewhere related to it. The next question is somewhat a theory and an application based question, if you see. So there's a drug A, which has an apparent volume of distribution as 100 liters. Drug B has an apparent volume of distribution of 5 liters. Both drugs are given orally. So now the question is, which among these two would actually require a loading dose, right? So you know, higher the volume of distribution, it's going to distribute further into your tissues, and you will require a loading dose to actually achieve that plasma concentration, the target plasma concentration, right? So the drug A, which has a high apparent volume of distribution of 100 liters, is the one which requires a loading dose. Okay. So let's see the second question first. Mention one possible reason each for such apparent volume of distribution of both drugs. So now see, this is slightly theory based. So application in this is that once you know the apparent volume of distribution, if it's high, you should keep it in your head that these are the drugs, these are the kind of drugs which require loading doses. Okay. So you could be asked also to name one example of a drug which has a high apparent volume of distribution. Okay. The question that has been asked over here, the reason for it. So this is slightly theory based, but it's also common sense. Any drug that is lipophilic, any drug that is less plasma protein bound may have high volume of distribution. So these are concepts you know. It is all a matter of putting it in the form of sentences in your answers. Okay. Let's move to the next question. So here again it's a figure based question. You have two concentration versus time curves. One is a straight line, one is a curve, so to say, for the drug B. So now out of these two concentration time curves, the question says, so these are two drugs which are given by IV administration. The question that is asked to you is that which of the two follows zero order kinetics. Okay. So far we have seen application in terms of distribution. So this is all GP, so I'm talking about pharmacodynamics and pharmacokinetics, right? So I'm slightly discussing on the pharmacokinetics side. So for pharmacokinetics, if you see anything, so zero order kinetics is a constant amount of drug that is excreted from the body per minute, per unit time. And when you talk about first order kinetics, it's the constant fraction of a drug which is excreted per unit time. Okay. So if the concentration that is excreted is constant, the amount of drug that is excreted is constant, you get a straight line, which you're well aware of from your theory classes. Okay. And consequently, this curve is obtained for drugs that follow first order kinetics. So out of these two, it is drug A which follows zero order kinetics. Alright. So over here in this question, I would also like to emphasize that you have to pay special attention to the y-axis, okay, to the marking or this title of the y-axis. Okay. So if this was log concentration, remember if it is a semi-log curve, the straight line represents a first order kinetics graph. Okay. So these are small little things which could confuse you. We try to give you easy questions, but there could potentially be such variations as well. Okay. Give one example of a drug which follows zero order kinetics. You could write warfarin, you could write theophylline, you could write tolbutamide. Any of the drugs that you know of, you could mention over here. It would be an acceptable answer. Okay. So for most questions that you have seen, for most questions that we discuss, we try to keep them as two-part questions so that if you get at least one of them right, you can score marks on it. Okay. And as you would have seen, they are fairly easy, fairly simple, but equally scoring. Okay, let's look at the next graph, next spotter. So this is a big figure. If you look at this, it might slightly scare you as to what is coming next. But then again, like I said, read the question in detail first. Name two drugs that induce microsomal enzymes involved in hepatic biotransformation. Whatever you remember, phenytoin, phenobarbital, rifampicin, griseofulvin, anything could be an acceptable answer. So although this question is related to it, this could be an independent spotter for you. Just this question written on the sheet. Okay. It's a very straightforward question with no words missed. Okay. So you could either have a question that asks you about enzyme inducers or enzyme inhibitors, which you should be aware of. It's a very important question. Okay. Right. Moving on. So far we saw drugs, questions somewhere or the other related to ADME, your pharmacokinetic aspect. Let's look at routes of administration. What kind of questions could you actually get from routes of drug administration? So this is partly from your theory aspect. This is also partly from what we discuss in the practicals. Okay. So over here, if you see, this is a rotahaler. Now you have to think of all the classes that you've done over here, whatever you remember. If you have your book with you, the practical manual that we would have given to you last year, you have these dosage forms also, these delivery systems also, to give you an idea. Okay. So what is shown over here is a dry powdered inhaler. Okay, specifically if you have to write, it's a rotahaler. Alright. So this drug delivery device, see, both answers are acceptable. Whether you write dry powder inhaler or you write rotahaler, both are acceptable answers. So you put the capsule over here. We are not as much bothered about the parts right now. So that is more for your experimental viva or your bench viva. Over here, like I said, these are small, simple answers. Okay. So what is one advantage of this device? Again, if you open your manual, you will be able to see the different advantages, the different disadvantages of each drug delivery system in brief. These have been discussed in different practical classes also, if you can remember, or these are also available in your manual. So easy way to remember, for any inhalational route if you have been shown, may it be say a metered dose inhaler, in the form of an inhaler in general, or this, or a nebulizer. See the activity, the drug is going to reach your target organ very quickly. It's going to be a very rapid absorption of the drug and a rapid onset of effect as well, depending on the drug, right? So that is one advantage that you can always remember for inhalational route. Right? The others, depending on the device, if you do well or if you're answering well in your viva, people may ask you the other advantages as well, which you should be in general aware of. Okay. They could ask you to describe this device, how the patient is going to use, what precautions will you ask the patient to take. Again, and what is the advantage of this device over a normal inhaler? These are easier to use, require less coordination as compared to the MDI or the metered dose inhaler. These are things that you could be asked on, and these are things that could also be a part of your questions. Okay, that this requires less hand-mouth coordination in for patients. Okay, so people who do not find it easy. The main problem with inhalational route in general is that when people cannot coordinate it well, the drug is not delivered adequately, hence there will be little effect. Okay. So that could be one question that you could be asked. Okay, easier delivery. So that is one advantage. Another form of question that you could be asked on this is that what drugs are delivered by this device. Okay. So any inhalational drug you can think of, starting from beta agonists. So drugs used for asthma, inhalational corticosteroids, budesonide, or like I said, salbutamol, beta agonist, and ipratropium. Like any asthma related drug you can think of could be a valid answer. Like again I said, this is more common sense. You're talking about inhalational route, you should always remember asthma. That is the one place, asthma, COPD, those are the places where you expect people to give drugs via inhalational route, right? So it's a little bit of theory, but you need to understand practically where you apply it. This is again a question from route of administration. This, if you see, if the picture is not very clear, because we sometimes have black and white images, so if the picture is not very clear, we will help you in the sense that the route will already be written on the image. So question associated over here, what is there is take the advantages of delivering drugs via this route. So by now, you're all aware, the advantage is quick action. There's going to be rapid absorption, quick action. Then it's going to bypass the first pass metabolism. Once the effect is attained, patient can spit out whatever leftover tablet is left in the mouth, which you cannot actually control if the patient has ingested the entire drug. Right? So those are some advantages associated with this. And you could also be asked, if it was a two-part question, they could ask you, state one advantage and name one drug that is delivered by this route. Most commonly we expect you to remember at least GTN, glyceride trinitrate. Alright, so common things are more common, so try to remember them. So this is not just the reason I've selected these two to be included in this discussion today is that one covers a route and one covers a drug delivery system, right? So a route could be anything that could be asked as a question. It could be intramuscular, it could be intravenous, it could be, subcutaneous, it could be just general as a transdermal patch. It could be a device in the form of a transdermal patch, or for that matter, even nanoparticles, other newer delivery systems. My point is that for every route, we already taught you what are the advantages, and we've always taught you what are a few examples of each route and each delivery system. Okay, both of this could be a part of your question in this quarter. Okay? Don't worry, they will not be very complicated, but you should know at least the common ones. Okay, so if I'm asking you for an example, you should know which condition it is going to be used in, things like that. Okay. Next, move on to the next system, which is the autonomic nervous system. So for autonomic nervous system, we already have two discussion classes, as a part of your practicals. So mainly we're looking for effect on your eye and your heart, but there are other forms of questions also that you could be asked, right? So that we will see how. So for most of your pharmacology related questions, anywhere you could be asked common drugs. You can be asked, you'll be given the figure of a drug, and you can be asked the drug class to which the drug in the given figure belongs to. Okay. So this is tamsulosin. We expect you to know that it's an alpha blocker. Okay, not just a sympatholytic drug or a vague classification for that matter. You should know it's an alpha blocker. We will be very happy if you go one step ahead and you call it an alpha-1 selective blocker. If you go and classify it into the subtypes, you will be even happier. But alpha-1 selective blocker is the most expected answer out of you people. Okay? You can classify it further. I'm not stopping you. Whoever remembers it, please go ahead. Next, write one indication for this drug. So, remember, common things are always common. For every drug class, for every drug, please remember the common indications. Okay, so when we are talking about alpha blockers, it's used for BPH, right, in elderly individuals. So if you're writing hypertension, you're partially correct, because hypertension, this is not the first line drug which you would give for hypertensive patients, right, for the simple reason that it's going to cause postural hypotension, which is something we don't want. It develops tolerance. So it has some problems because of which it's not given as a first line antihypertensive agent. Alright. So when we talk about indication, please do not forget benign prostatic hyperplasia, right? BPH. Second, if it says, it could also ask what are the conditions in which this drug will not be given, right? And patients who are prone for hypotension for that matter, who are receiving some other drug which causes like nitrates, which causes hypotension, things like that. So it could either be an indication, it could be an adverse effect, it could be a drug interaction, it could be any of those forms. But for your sake, most of these questions you'll be asked to classify which drug category does this drug shown in the figure belongs to, and mostly it will be an indication or an adverse effect as your question along with it. Okay. Second type of question in ANS related spotters will be from your ANS related exercises that we usually have, like I said, on the heart and on the eye. So over here, if you see, so we've shown you the normal eye, and if you see over here, clearly the pupillary size has reduced. So identify the condition on the affected eye. If you're seeing along with me, you know this is meiosis, pupillary constriction, whatever you want to call, meiosis will be the preferred answer. And name two drugs which can produce this condition. You can name anything, any drug which causes myosin, you can feel free, starting from pilocarpine, like whatever you want to name. It could either be cholinergic or it could be sympatholytic if it is causing pupillary change. Now again, go back to what we've discussed in your ANS related exercises. Alright. So even if you went ahead and said for constriction, opioids, it's also an acceptable answer, because even that causes constriction of pupils. Alright. So remember that if it specifically says name one cholinergic drug which causes this, you could again specifically go for the cholinergic drugs. So read your questions carefully. Somewhere or the other you know the answer. So just try to assess what has been asked and answer accordingly. Right. So that was one aspect. So if like we teach you for AIIMS related exercises, if it is say meiosis and we've given you a drug, or say if it's metiasis and we've given you a dropin. So there could also be questions as to what other reflexes would be lost or would be present. So it's a direct application of whatever has been taught to you in practical lessons. See, it may seem irrelevant right now, but when you eventually go for your ophthal postings, it becomes relevant. Hence the reason for including it in our classes also. Okay. Let's move on. So this is the second part that we teach usually, the effect on heart rate, the cardiovascular effects. So heart rate and blood pressure. Okay. So for all those classes where we've discussed the effects of autonomic nervous system on the heart rate and the blood pressure. So these are a few graphs which would have been given to you then, which would have been discussed with you then, which can be asked in the form of a spotter. So if that is the question, you could be asked, you could be shown the recordings of the effect of drugs on BP as well as heart rate of an anesthetized animal. So sorry, the thick line over here, which means this line represents the blood pressure, whereas the thin line represents the heart rate. So this part represents the heart rate. If you see the drugs over here, EPI is epinephrine, PHEN is phentolamine. So you should know epinephrine is an adrenergic drug with activity on both alpha as well as beta receptors, whereas phentolamine is a alpha blocker, right? So again, if you remember from your practical, from your theory classes, so when you give epinephrine initially, you are expecting a biphasic response in blood pressure. Yeah? It's going to be an increase in blood pressure because of predominantly alpha activity at higher concentration, and eventually there's going to be a dip in blood pressure because of predominantly beta 2. This is alpha 1, this is beta 2 activity at lower concentrations, right? So when you add an alpha blocker, right, after addition of an alpha blocker, if you repeat the same dose of epinephrine, you're not going to get a biphasic response, but you're going to observe only a fall in blood pressure, right, which is known as vasomotor reversal of Day. Right? So you know this phenomenon, it's been told to you over and over again. You could get any variation of it. The reason we include things like this is because it's been already discussed with you in your practical classes. So the next question will be what is the cause for this phenomenon. Like I said, if you're writing in detail, we expect that you at least mention that there's an initial biphasic response which is reduced to a fall in blood pressure because of alpha blockade by phentolamine. Okay. So this could be one form of questions. You could also be given, say, the action of atropine. You could be given tachyphylaxis, so you will be going to have reductions in the activity of the drug. That could also be a graph. So everything that we discussed there in the form of a graph can be asked as a spotter. Okay, that's simple ones, not the complicated ones which we don't think you'll be able to answer. So these are easy concepts that you inherently remember. I'm just trying to tell you which are the different forms in which these questions can be asked. Right? Let's move to the next question. So out of all these, so a spotter is not just your ability to answer, say, 2 or 3 questions quickly, but it's also to check whether you can, quickly assess the situation and give an answer or not, which will be your condition in few years down the line where you'll have to make quick decisions as well, right? So if you see, this is in the form of a case, but okay, let's just read the case once. A 35-year-old farmer was brought to the emergency within an hour of ingestion of a 250 ml pesticide. Right? On examination, he has copious oral secretions, pinpoint pupils, profuse sweating, diarrhea, uncontrolled urination. Also, there are crepitations in both the lungs. The heart rate was 54, which means it's bradycardia. The BP was 170, which is hypotension. And the RBC cholinesterase activity was 10% of the baseline. Right? So, as far as possible, we try to give you straightforward situations. Okay, at your level, you should understand or you should develop the ability to identify toxidromes. It may or may not be similar in a clinical setting, but as far as this pesticide is concerned, it's not that difficult to diagnose even when you look at the case clinically, right? So you can see there are increased secretions even in the lungs, this bronchoria, hence the crepitations. There is a reduction in heart rate and there is hypotension. An additional clue that we've given over here is that the cholinesterase activity is also reduced. By the time I finish the question, I think half of you would have guessed we're talking about organophosphate poisoning. So organophosphates, which are commonly used as pesticides, the toxicity of it or the poisoning of it is fairly common amongst farmers. So everything is in the form of a clue in this question if you see. Okay. So once you identify the class of pesticides, it's easy enough to state what the antidote is. So specific antidote is atropine. PAM is a reactivator of the enzyme but is also acceptable as an answer for antidote. But the first thing that should come to your head is atropine. The next question, if we were asking or if we've given you that it's an OP pesticide over here, a variation of it could have been is what is the specific antagonist which is used as an antidote. So remember, PAM is not an antagonist, okay? It is atropine, which is the muscarinic antagonist which reduces all these effects of OP poison or organophosphate. Okay, so remember that, and I think that should be enough. So if it's an enzyme reactivator specifically, we are expecting pralidoxime or obidoxime from you. Okay, but please remember you start your answer with atropine. And you remember how both of them are useful in organophosphorus poisonings. Okay. So this is another variation which was discussed in the last class also, which you would have seen in your practical spotters. If I think you would have given it in your third semester. So here you've been asked to make the most suitable match of the following. So for these questions, the trick to them is to approach them like multiple choice questions, like MCQs. So go from the one that you actually know. Okay. So say I've forgotten all these three and I remember only NM receptor. Okay. I know this is present on the muscle because of the M, which is a short clue over here. So right, it's going to cause skeletal muscle contraction. Nothing else is related. I remember, okay, there is beta-1 receptor which increases everything in the heart. Right? The adrenergic effect on the heart is mediated via beta-1 receptors. So you go back to all your increase chronotropic, inotropic, dromotropic, whatever. So you know that as well. So with this, I go for increased force of contraction, cardiac contraction. Okay? That also has been made clear. Now, out of these two, if you're confused, you can always remember this is present in the blood vessels, alpha 1. It constricts, the blood vessels. So go to vasoconstriction. So what you're left with is M2 receptors and slowing of heart. Okay. So try to go with the ones that you're most confident about and then try to write the answer along with it. So for questions like these, please be very careful when you're marking your answers. Right? You're thinking D but you're writing C, you're going to lose marks unnecessarily. Right? So just be very careful when you're writing the options. If you have confusion, just write the entire statement. Easier for you if you're confused. Right. So that concludes our autonomic nervous system. Let's look at questions that you can be asked from cardiovascular system. So cardiovascular system, there are again, like we asked you for tamsulosin, there can be questions on propranolol, there can be questions, labetalol, a drug can be kept, you could be asked the class and the indication. Or a variation of that for common sources alone could be that you're given the image of the plant source from where the drug is obtained. Okay. So here, if you remember from your source of drugs class, this is foxglove. We would have taught the plant digitalis to you. If it's not a black and white photo and if it's a color photo, this is either yellow or it's pink. Another plant of the same genus actually is digitalis purpurea, right? So please don't get confused with it. Digitalis lanata is the one from where we get digoxin, and hence we've included this image to sensitize you. That this is the plant from where we get digoxin. We get digitoxin from purpurea. Both of them are cardiac glycosides. Okay, so if you're writing medicines obtained from these plant, if it is lanata, remember it is digoxin. I know it's a little out there to for you to remember, but when you see digitalis, at least remember digoxin or digitoxin, right? From lanata it is digoxin, or we might just give you digitalis plant or digitalis species for that matter. Okay, so call it cardiac glycosides, call it digoxin or digitoxin, they're all acceptable. If it is specific, it would be preferable that you called it digoxin, right? So mention two important adverse effects of this medicine. So normally your instinct to write adverse effects for most people you observed is nausea, vomiting. And funny enough, nausea, vomiting are good answers for this question, because digitalis in itself or digoxin itself causes gastric irritation. It causes CTZ stimulation, because of which it does actually cause nausea and vomiting. So there are extra cardiac side effects of digoxin. But what the second adverse effect and second important adverse effect that we would want you to remember is that it produces cardiac adverse effects, right? Because it has a direct effect on the heart, it's going to have any form of arrhythmia you write is acceptable. Generally arrhythmias or ventricular fibrillation are acceptable answers. Whatever you remember from that clan is okay. If you go to the extent of saying pulses by Geminis, if you remember the terminology, good. If not, arrhythmia is also a good answer. Okay. So what is the antidote used in case of toxicity by this medicine? See, when we are mentioning this specific antidote, although it's not available in India, it's fine text in your books also. Digibind is a specific antibody that is used to revert the adverse effects or the cardiac toxic effects of digoxin. Okay. You could also be asked an indication for this, for digoxin. The only indication is atrial fibrillation. So it's a very narrow therapeutic index drug, right? So the reason we've included this is just because you need to know that you can be asked based on the source of drug as well, right? With the image of a plant. Okay, so like we saw for tamsulosin, here is another question with related to CVS. So when you're talking about sildenafil, again, see, they have a very similar, write the mechanism of action of the drug. So if you remember, this drug belongs to PDE5 or phosphodiesterase 5 inhibitor group, you will directly remember the mechanism by which it acts also. Okay, so the second question is slightly application oriented based. In the sense it's asking you whether it can be taken by a subject who's already on nitroglycerin. So sildenafil itself causes profound, so it can cause postural hypotension, right? So any other substance like nitroglycerin, which can also cause postural hypertension, the effect will be exaggerated, and hence you're not going to combine both of them together. So your answer is no, it's going to exacerbate the postural hypertension, which leads because of sildenafil. Sildenafil is going to increase the postural hypertension due to a nitrate, right? Both of them have similar mechanisms in terms of the CGMP related pathway. Okay, so remember that much. If it should be a recollection for you, hopefully useful. Okay, so let's move on to the next kind of question. See, as far as pharmacology is concerned or any medical subject is concerned, it's going to be somewhere or the other linked to other things as well. So although I'm talking about aspirin and its use in cardiovascular illnesses, you could also argue that this is a question in autocoids. Okay, so although we've tried to separate it into three different classes for your sake to divide it semester wise, you will see how all of them are eventually linked together. So over here, if you see, there are two aspirin tablets. One is low dose aspirin 75 milligram. Another is aspirin 500 milligram. So this is the analgesic dose, which is the, so aspirin is an NSAID, please recollect from your classes, which can be used as a painkiller, as an antipyretic, but at low doses, the predominant effect it has is antiplatelet aggregatory, right? So for both, for this you can write fever if you remember anything specific for any pain, and over here you can write for prophylaxis of MI. So you could, instead of indication, you could also be asked what is the mechanism by which the low dose and high dose act. So again, like I said, This is antiplatelet aggregatory, and this is an analgesic. So COX-2 inhibition. Actually, it's COX-2 inhibition for both. So you'll also be asked the mechanism and the effect at low and high doses. Right. So let's move on. This is slightly towards your blood hematology side. So this is the vitamin K cycle. If you see over here, it's V-corp, oxidoreductase complex of vitamin K, which is affected. I don't know if you remember that much, but if you're asked to identify drug X, remember anything that is going to block this cycle, the drug is essentially what? Is essentially warfarin. You know? So I hope you remember that and you are with me still. So what specific lab parameter will you monitor? The answer we are expecting from you is warfarin causes bleeding, right? So PT-INR. So you're going to see even if you write INR, international normalized ratio, that's the one that's usually monitored. See, we are not asking you to remember till what level. That's going to come later when you gain a little more clinical experience. But for now, we're not even asking you the normal ranges of INR. You know? So, but you should know that whenever there's a drug like warfarin which is causing bleeding, you monitor the INR, okay? Because of its tendency to cause bleeding by blocking this vitamin K. Okay. So if you go by PT-INR, if you're going concept-wise, you can see the essentially the what conversion that it's stopping. Okay, what clotting factors does it stop from conversion? Okay, that you could probably see if you're interested. I will not bore you further. Let's move on. So one form of questions like you saw for OP insecticides. So that it's a similar kind of question. It's essentially a case-based poisoning question, and we usually try to give you such questions because, especially this question, because a lot of you get it wrong in your practical exams. So just remember, it's a very similar question that we have could possibly be asked for one of the batches. So, a 3-year-old male child presented with one episode of hematemesis after accidental ingestion of a rodenticide. So, OP and all we expect you to remember. For rodenticide, it is a super warfarin which actually causes bleeding tendencies. You know? So, there is hematemesis which is giving you an indication of bleeding tendency. So, you have to identify the class of rodenticide. It's slightly a difficult term. Bromadiolone, if you can remember it, good. If you cannot remember bromadiolone, you could always remember super warfarin. Okay. So when I'm saying super warfarin, I've already told you that you have to monitor INR. So with this rodenticide, you have to specifically monitor INR again. And the specific antidote, see, these are all competitive inhibitors. You know? So vitamin K in that case becomes the specific antidote. Okay. So this is a slightly offbeat question which we've asked in the past. So it will be helpful if you remember this. The others usually you would get somewhere in the books, but this is a little different. Okay. So, so far I have discussed questions that would be asked in the form of image-based questions, or just questions, you know, themselves, or they could be case-based questions, or they could be matched to following kind of questions. Another question in spotters that you are frequently asked is mechanism-based question. Okay. So if you see over here, this is HMG coenzyme A, I'm not reading the entire name, and there is an enzyme X which converts it to mevalonate, which accelerates the conversion to mevalonate. So if you remember HMG coenzyme A, the reductase is the one that converts it to mevalonate, and statins are the one which block this enzyme and are useful for hyperlipidemias, dyslipidemias rather, right? So it could be, like I said, it is an application somewhere or the other of what you know. So you know some amount of it from your biochemistry. So now you learn in pathology about how things are deranged, and you learn in pharmacology about how drugs target this derangement to eventually normalize these parameters, right? So if you remember from biochemistry, you know that there is going to be HMG-CoA reductase enzyme over here, and application from our end is a blocker of this enzyme, which are statins. Okay, so we are talking about name a drug specifically, so please don't write statins as a general group, but write the name of one statin, any statin, you know, atorvastatin, rosuvastatin, pitavastatin, anything is acceptable. Okay, just read the question and then answer. Right. So again, this is a question based on a case. not get very confused depending on the details that are given over here. So if you see, the patient was being treated with an ACE inhibitor and eventually she started on spironolactone, both of which can cause changes in the potassium levels. So in ECG, if you have peak T waves, I think you know that it is because of hyperkalemia. This is again an application from your first year physiology, right? So add pharmacology to it, you have certain drugs which are causing hyperkalemia, which is seen as peak T waves on an ECG. So your question, if you see, which electrolyte imbalance can lead to such changes? I gave you the answer, potassium. And name two drugs from different classes which can cause the above mentioned electrolyte imbalance. See, for those who have read the question, you have the answer even before I say anything. So you have ACE inhibitors and you have diuretics, potassium sparing diuretics, both of which can cause an increase in or a derangement in potassium levels. So if they're asking about this specific electrolyte imbalance, you cannot mention drugs such as say loop diuretics which cause potassium loss. We want you to name drugs which cause hyperkalemia. So the clue in this again is in the question itself. So it's a variant of question where if you've read the question correctly, you can answer it even by reading from the question itself, without breaking too much of your head. Right, I think this is the last question, if any of you or all of you are still awake. So if you see, this is your nephron and there are different sites at which your diuretics act, which have been numbered over here. So let's see what the question reads. So lab investigations for a 45-year-old male who's been treated with a diuretic was found to be this is an incomplete question, I'm really sorry. The calcium level was found to be 8.2 milligram per deciliter. Okay. So now what is the diuretic? The diuretic acting on which side could have caused this effect? So this is 8.2 mg per deciliter of calcium, right? So there is a reduction in serum calcium levels. So if you remember, loop loses calcium. So hypocalcemia is caused by a loop diuretic. So the question is not which diuretic is causing it, but which site. So we expect you to answer not thick ascending limb of Henle, but because it's numbered site 3 and thick ascending limb of loop of Henle, right? Next, you could also be asked as a variation, what is the specific transporter which gets affected, right? So it could be sodium potassium chloride. That could be a question or a sub part of the question, or like as it has been given over here, they give two examples of drugs which belong to this class. So any two drugs starting from furosemide, torsemide, indapamide, whatever, bumetanide, whatever you remember from this group you can give. Okay, so the variation of this we could give you depending on the effect of the drug. Okay, so like we saw potassium sparing diuretics in the last question, which was causing hyperkalemia as a consequence. Here I am showing you a case which led to hypocalcemia. Okay, so I think that's the end of it. Okay, thank you for bearing with me for almost 50 minutes, I guess. See, the purpose of this revision class, please take it, if you've read some part of pharmacology also, please take it as a revision exercise for yourself, because we tend to discuss a few things that are pharmacology related. Tips and tricks I've told you along the way. I have tried to show you different types of spotters which are related to these three systems. Although this is not an exclusive list of the questions that you may get, but most of them are related or similar questions only. Okay, so if you remember the main mechanisms or the classes which the drugs belong to, its adverse effects and its uses, it's mostly sufficient to answer all the questions that you get. Specific practical related questions we've tried to discuss in your practical classes also, and you can go through your manual as well to get an answer or to get an idea about the answers that or the questions that could be answered. Okay, again I want to repeat, it's not that hard, and we will discuss the other systems in depth as well so that you get a better idea. Okay, so the pattern will remain essentially the same, the type of questions will remain the same, but depending on the different system, if there's anything specific, we've tried to touch upon it so that you're sensitized with it again before your exams. Alright, with that I'll end today's class. Thank you for patiently listening. If anyone has any questions, you can ask. Okay, I think we call it a day, and tomorrow you can join back again for your fourth semester revision of spotters. Okay.